Your body's immune system protects you from disease and infection. But if you have an autoimmune disease, your immune system attacks healthy cells in your body by mistake. Autoimmune diseases can affect many parts of the body. No one is sure what causes autoimmune diseases. They do tend to run in families. There are more than 80 types of autoimmune diseases, and some have similar symptoms. This makes it hard for your healthcare provider to know if you really have one of these diseases, and if so, which one. Getting a diagnosis can be frustrating and stressful. Often, the first symptoms are fatigue, muscle aches, and a low fever. The classic sign of an autoimmune disease is inflammation, which can cause redness, heat, pain, and swelling. The diseases may also have flare-ups, when they get worse, and remissions, when symptoms get better or disappear. Treatment depends on the disease, but in most cases one important goal is to reduce inflammation. Sometimes doctors prescribe corticosteroids or other drugs that reduce your immune response.
Goodpasture syndrome is an autoimmune disease that primarily affects two organs, the lungs and the kidneys. It causes inflammation and eventually bleeding in the lungs, which leads to hemoptysis, or coughing up of blood, and hematuria, or blood in the urine, a pattern first recognized by the pathologist Dr. Ernest Goodpasture. To understand Goodpasture syndrome, let's start by thinking about the basement membrane, which is a thin, sheet-like layer of tissue made of protein that keeps the epithelium stuck firmly to the actual organ, kind of like double-sided tape, which keeps wrapping paper stuck to the gift. This basement membrane is made up of various proteins, but the major one is collagen. And since basement membrane exists throughout every organ system, it's no wonder that collagen is the most abundant protein in the human body. As far as proteins go, collagen's a pretty sweet-looking one, with a triple helix structure composed of 3 separate chains that are intertwined like braided hair. Each of the chains can be one of 6 types, named alpha 1 through alpha 6. And the most common form of collagen found in the basement membrane is collagen type 4, which is made by mixing and matching these 6 alpha chains. One version of type 4 collagen combines the alpha 3, alpha 4, and alpha 5 chains. Another combines 2 alpha 1s and an alpha 2. And a third version has 2 alpha 5s and an alpha 6. And this list of combinations goes on. So it turns out that the alpha 3, alpha 4, alpha 5 variant is most common in the glomerular basement membranes of the kidneys and the alveolar basement membrane of the lungs. In Goodpasture syndrome, autoantibodies bind to a specific part of the alpha 3 chain that's usually hidden deep within the folded chains. This is an example of a type 2 hypersensitivity reaction, because once these autoantibodies, usually IgG but rarely IgM or IgA, bind to the alpha 3 chain, they activate the complement system. Now, the complement system is a series of small proteins present in the blood that act like an enzymatic cascade to fight off bacterial and other pathogenic invasions. When the FAB portion of the IgG molecule inappropriately binds to the alpha 3 chain, C1, which is the first of the complement proteins, binds to the FC portion of the IgG molecule. This bound C1 is now activated, and it starts engaging other members of the complement family, C2 through C9. Some of these are activated by being cleaved or chopped by an enzyme. The cleaved fragments C3a, C4a, and C5a act as chemotactic agents, meaning they attract certain cells like neutrophils. Once neutrophils join the party, they dump a bunch of enzymes like peroxidase, myeloperoxidase, and proteinase 3, which all cause free oxygen radicals to form, which damage the basement membrane as well as the nearby endothelium and the underlying organ itself. Genetic risk factors for Goodpasture syndrome include having genes that encode a specific type of immune molecule called HLA-DR15, which is used to identify and bind to foreign molecules. Environmental risk factors, on the other hand, also play a role. and it relates back to the fact that the autoantibodies bind to a specific part of the alpha-3 chain that's usually hidden deep within the folded chains. When the collagen molecules are damaged by infection, smoking, oxidative stress, or some hydrocarbon-based solvents, as in the case of people who work in the dry cleaning industry, these antigenic regions on the alpha-3 chain get exposed to the antibodies present in the blood of genetically susceptible people. This also helps explain why Goodpasture syndrome specifically affects the kidney and the lungs. The kidney filters toxins from the blood, so as they pass through the basement membrane of the kidney, they likely expose parts of the alpha-3 chain. And similarly, the lungs get exposed to various inhaled toxic substances, like cigarette smoke, once again exposing the parts of the alpha-3 chain that leads to Goodpasture syndrome.
Autoimmune hemolytic anemia refers to increased red blood cell hemolysis, or breakdown, that results when a person's own antibodies target red blood cells for destruction. And this results in a lower than normal amount of red blood cells anemia. The disease is most often idiopathic, or without a known cause, but it can be related to a medication side effect or an underlying disease process.
This anemia is a type of megaloblastic anemia caused due to the lack of a substance called intrinsic factor, which leads to deficiency of vitamin B12. Now, intrinsic factor is a glycoprotein produced by parietal cells in the fundic region of the stomach that helps vitamin B12 to be absorbed by the body. Vitamin B12, along with folate, is necessary for the synthesis of a protein called thymidine. Now, thymidine forms one of the building blocks of DNA, and deficiency of thymidine causes abnormalities in rapidly dividing cells of the body, especially red blood cells. Impaired DNA formation in the erythrocyte precursors leads to premature apoptosis of these cells in the marrow, causing a dip in the number of red blood cells, leading to anemia.
Let's start with type 1 diabetes mellitus, sometimes just called type 1 diabetes. In this situation, the body doesn't make enough insulin. The reason this happens is that in type 1 diabetes, there's a type 4 hypersensitivity response, or a cell-mediated immune response, where a person's own T cells attack the pancreas. As a quick review, remember that the immune system has T cells that react to all sorts of antigens, which are usually small peptides, polysaccharides, or lipids, and that some of these antigens are part of our own body's cells. It doesn't make sense to allow T cells that will attack our own cells to hang around. And so there's this process to eliminate them called self-tolerance. In type 1 diabetes, there's a genetic abnormality that causes a loss of self-tolerance among T cells that specifically target the beta cell antigens. Losing self-tolerance means that these T cells are allowed to recruit other immune cells and coordinate an attack on these beta cells. Losing beta cells means less insulin, and less insulin means that glucose piles up in the blood, because it can't enter the body's cells. One really important group of genes involved in regulation of the immune response is the human leukocyte antigen system, or HLA system. Even though it's called a system, it's basically this group of genes on chromosomes that code the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. It's like the serving platter that antigens are presented to the immune cells on. Interestingly, people with type 1 diabetes often have specific HLA genes in common with each other. One called HLA-DR3, HLA-DR4. But this is just a genetic clue, right? Because not everyone with HLA-DR3 and HLA-DR4 develops diabetes. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, but sometimes up to 90% of the beta cells are destroyed before symptoms crop up. 4 clinical symptoms of uncontrolled diabetes that all sound similar are polyphagia, glycosuria, polyuria, and polydipsia. High glucose levels, that means that when blood gets filtered through the kidneys, some of it starts to spill into the urine, called glycosuria. Glycose refers to glucose, and urea, the urine. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Poly again refers to a lot, and urea again refers to urine. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated and thirsty, or polydipsia. Poly means a lot, and dipsia means thirst. Even though people with diabetes are not able to produce their own insulin, they can still respond to insulin. So treatment involves lifelong insulin therapy to regulate their blood glucose levels and basically enable their cells to use glucose. About type 2 diabetes, which is where the body makes insulin, but the tissues don't respond as well to it. The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to their membrane in response, which remember is needed for the glucose to get into the cells. These cells therefore have insulin resistance. Some risk factors for insulin resistance are obesity, lack of exercise, and hypertension, and the exact mechanisms are still being explored. For example, an excess of adipose tissue, or fat, is thought to cause the release of free fatty acids and so-called adipokines, which are signaling molecules that can cause inflammation, which seems related to insulin resistance. Described by Irish surgeon Robert James Graves, Graves' disease is an autoimmune disorder that causes hyperthyroidism. In hyperthyroidism, hyper refers to having too much, and thyroid refers to thyroid hormone. So Graves' disease refers to a condition where there's excess thyroid hormones. Now, normally the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or just TSH. TSH stimulates the thyroid gland, which is a gland in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, which is a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, at which point it can exert its effect. T3 speeds up the basometabolic rate, so as an example, they might produce more proteins and burn up more energy in the form of sugars and fats. It's like the cells are in kind of a frenzy. T3 also increases cardiac output, stimulates bone resorption, which thins out the bones, and activates the sympathetic nervous system, which is the part of the nervous system that's responsible for our fight-or-flight response. That being said, thyroid hormone is important, and the occasional increase is kind of like getting a boost to fight off a hungry predator or to stay warm during a snowstorm. Now, in Graves' disease, the trigger is unclear, but for some reason, the B cells start to produce a few different types of antibodies against thyroid proteins. The most common antibody is the thyroid-stimulating immunoglobulin, which binds to the TSH receptor on thyroid cells, thereby imitating TSH, and stimulating the thyroid cells to release more T3 and T4. But the effects of thyroid-stimulating immunoglobulins can also directly affect certain tissues. First, thirst essentially affects young women in their 20s and 30s, and older men in their 60s and 70s. But the cause of this odd, bimodal distribution of age of onset isn't quite clear. To better understand myasthenia gravis, though, let's review normal muscle contractions, but at the cellular level. First, you've got your motor neurons that release the neurotransmitter acetylcholine at the neuromuscular junction. Neurons that release the neurotransmitter acetylcholine at the neuromuscular junction, which then binds to nicotinic acetylcholine receptors on the muscle cell membranes. Binding of acetylcholine to its receptor activates a chain reaction in the muscle cell that ultimately results in muscle contraction. But what happens in myasthenia gravis, though? Well, remember that it's an autoimmune disease, and specifically one that's categorized as a type 2 hypersensitivity, which causes cytotoxic injury, meaning that it results in the lysis or death of host cells, which is mediated by autoantibodies, which are antibodies that are specific for our own cells or proteins. Alright, so in this case, the patient's B cells inappropriately make antibodies that bind to nicotinic acetylcholine receptors on the muscle cells. Once acetylcholine receptors are bound by the antibody, they're unable to bind the acetylcholine, and therefore they don't respond to the contract signal from the central nervous system. Anti-acetylcholine receptor antibodies can also activate the classical complement pathway. Now, the complement system is a family of small proteins that work in an enzymatic cascade to fight off bacterial infections. The activation of complement causes inflammation and destruction of the muscle cells, and reduces the amount of acetylcholine receptors on the surface. Multiple sclerosis is a demyelinating disease of the central nervous system, which includes the brain and the spinal cord. Myelin is the protective sheath that surrounds the axon of neurons, allowing them to quickly send electrical impulses. This myelin is produced by oligodendrocytes, which are a group of cells that support neurons. In multiple sclerosis, demyelination happens when the immune system inappropriately attacks and destroys the myelin, which makes communications between neurons break down, ultimately leading to all sorts of sensory, motor, and cognitive problems. Now, the brain, including the neurons in the brain, is protected from things in the blood by the blood-brain barrier, which only lets certain molecules and cells through from the blood. For immune cells like T and B cells, that means they have to have the right ligand or surface molecule to get through the blood-brain barrier. This is kind of like having a VIP pass to get into an exclusive club. Once a T cell makes its way in, it can get activated by something it encounters. In the case of multiple sclerosis, it's activated by myelin. Once the T cell gets activated, it changes the blood-brain barrier cells to express more receptors, and this allows immune cells to more easily bind and get in. It's kind of like bribing the bouncer to let in a lot of people. Now, multiple sclerosis is a type 4 hypersensitivity reaction, or a cell-mediated hypersensitivity. And this means that those myelin-specific T cells release cytokines like interleukin-1, interleukin-6, tumor necrosis factor alpha, and interferon gamma, which together dilate the blood vessels, which allows more immune cells to get in, as well as directly cause damage to the oligodendrocytes. These cytokines also attract B cells and macrophages as part of the inflammatory reaction. Those B cells start to make antibodies that mark the myelin sheath proteins, and then the macrophages use those antibody markers to engulf and destroy the oligodendrocytes. Without oligodendrocytes, there's no myelin to cover the neurons, and this leaves behind areas of scar tissue, also called plaques or sclera. In multiple sclerosis, these immune attacks typically happen in bouts. In other words, an autoimmune attack on the oligodendrocytes might happen, and then regulatory T cells will come in to inhibit or calm down the other immune cells, leading to a reduction in the inflammation. Early on in multiple sclerosis, the oligodendrocytes will heal and extend out new myelin to cover the neurons, which is a process called remyelination. Unfortunately, though, over time, as the oligodendrocytes die off, the remyelination stops, and the damage becomes irreversible with the loss of axons. Just like other autoimmune diseases, the exact cause of multiple sclerosis is unknown. It turns out that there are actually 4 main types of multiple sclerosis, based on the pattern of symptoms over time. To break this down, we can use a graph with time on the x-axis, where time refers to the lifespan of the individual, and disability on the y-axis. The first and by far the most common pattern of multiple sclerosis is called relapsing remitting multiple sclerosis, or RRMS. This condition is what we just described, bouts of autoimmune attacks happening months or even years apart, and causing an increase in the level of disability. For example, during a bout a person might lose some vision, but then it might be followed by improvement if there's remyelination. Unfortunately though, more often than not, the remyelination process isn't complete, so there's often some residual disability that remains. And that means that with each attack, more and more the central nervous system gets irreversibly damaged. In the relapsing remitting multiple sclerosis type, there's typically no increase in disability between bouts, so the line stays flat during that time. Now, the second type is called secondary progressive multiple sclerosis, or SPMS. which initially is pretty similar to the relapsing remitting type, but over time the immune attack becomes constant, which causes a steady progression of disability. The third type is primary progressive multiple sclerosis, or PPMS, which is basically one constant attack on myelin, which causes a steady progression of disability over a person's lifetime. The final type is progressive relapsing multiple sclerosis, or PRMS, which is also one constant attack, but this time they're about superimposed, which means the disability happens even faster.
In rheumatoid arthritis, arth refers to joints, itis means inflammation, and rheumatoid comes from rheumatism, which more broadly refers to a musculoskeletal illness. So rheumatoid arthritis is a chronic inflammatory disorder that mostly affects the joints, but can also involve other organ systems, like the skin and the lungs as well. Alright, so a healthy joint typically has two bones covered with articular cartilage at the ends. Articular cartilage is a type of connective tissue that acts like a protective cushion. It's a lubricated surface for bones to smoothly glide against. One type of joint, like the knee joint, is called a synovial joint. A synovial joint connects two bones with a fibrous joint capsule that is continuous with the periosteum, or the outer layer of both bones. The fibrous capsule is lined with a synovial membrane that has cells that produce synovial fluids and remove debris. The synovial fluid is normally a viscous fluid like a jelly part of a chicken egg, and it helps to lubricate the joint. To help serve these synovial cells, the synovial membrane also has blood vessels and lymphatics running through it. Together, the synovial membrane and the articular cartilage form the inner lining of the joint space. Rheumatoid arthritis is an autoimmune process that's typically triggered by an interaction between a genetic factor and the environment. For example, a person with a certain gene for an immune protein, like human leukocyte antigen, or HLA-DR1 and HLA-DR4, might develop rheumatoid arthritis after getting exposed to something in the environment, like cigarette smoke, or a specific pathogen, like a bacteria that lives in the intestines. These environmental factors can cause modification of our own antigens, such as IgG antibodies or other proteins like type 2 collagen or vimentin. Type 2 collagen and vimentin can get modified through a process called citrullination. That's when the amino acid arginine found in these proteins is converted into another amino acid, citrulline. Meanwhile, due to the susceptibility genes, HLA-DR1 and HLA-DR4, immune cells are sometimes not clever enough, so they get confused by these changes and they no longer recognize these proteins as self-antigens. The antigens get picked up by antigen-presenting cells and get carried to the lymph nodes to activate CD4 T helper cells. T helper cells stimulate the nearby B cells to start proliferating and differentiate into plasma cells, which produce specific autoantibodies against these self-antigens. In rheumatoid arthritis, T helper cells and antibodies enter the circulation and reach the joints. Once there, T cells secrete cytokines like interferon gamma and interleukin-17 to recruit more inflammatory cells like macrophages into the joint space. Macrophages will also produce inflammatory cytokines like tumor necrosis factor or TNF-alpha, interleukin-1 and interleukin-6, which together with the T cell cytokines stimulate synovial cells to proliferate. The increase in synovial cells and immune cells creates a pannus, which is a thick, swollen synovial membrane with granulation or scar tissue made up of fibroblasts, myofibroblasts, and inflammatory cells. Over time, the pannus can damage the cartilage and other soft tissues, and also erode bone. Activated synovial cells also secrete proteases, which break down the proteins in the articular cartilage. And without the protective cartilage, the underlying bones are exposed and can directly rub against each other. In addition, inflammatory cytokines increase a protein on the surface of T cells known as RANK-L, or receptor activator of nuclear factor kappa B ligand. RANK-L allows T cells to bind RANK, a protein on the surface of osteoclasts, to get them to start breaking down bone. Meanwhile, antibodies also enter the joint space. One antibody is called rheumatoid factor, or RF, which is an IgM antibody that targets the constant Fc domain of altered IgG antibodies. Another antibody is anticyclic citrullinated peptide antibody, or CCP, which targets citrullinated proteins. When these antibodies bind to their targets, they form immune complexes, which accumulate in the synovial fluid. There, they activate the complement system, a family of 9 small proteins that work in an enzymatic cascade to promote joint inflammation and injury. Finally, the chronic inflammation causes angiogenesis, or the formation of new blood vessels around the joint, which allows even more inflammatory cells to arrive. As the disease progresses, multiple joints on both sides of the body get inflamed and gradually destroyed. But these inflammatory cytokines don't just stay within the tight joint space. Instead, they escape through the bloodstream and reach multiple organ systems, causing extra-articular problems, meaning problems beyond the joint space. For example, interleukin 1 or 6 travel to the brain, where they act as pyrogens, inducing fever. In skeletal muscle, they promote protein breakdown, and in the skin, as well as many visceral organs, they lead to the formation of rheumatoid nodules, which are round-shaped collections of macrophages and lymphocytes with a central area of necrosis, or tissue death. Blood vessels can also be affected. Their walls get inflamed, resulting in various forms of vasculitis, and make them prone to developing atheromatous or fibrofatty plaques. In response to inflammatory cytokines, the liver also starts producing high amounts of hepcidin, a protein that decreases serum iron levels by inhibiting its absorption by the gut and trapping it into macrophages or liver cells. Meanwhile, within the lung interstitium, fibroblasts get activated and proliferate, causing fibrotic or scar tissue that makes it harder for the alveolar gas exchange,